Maybach music.
Can anybody out there hear me?
Welcome to the first session of the ICU curriculum. This session will be an introduction to the ICU. Our objectives for the session are to review ICU training in medical school, describe the purpose of the intensive care unit, identify a method of presenting vital signs in the ICU, including vasopressor requirements and ventilator settings, and demonstrate a systematic approach to presenting the objective portion of the bedside rounding presentation. Let's start by briefly discussing ICU training in medical school. The Association of American Medical Colleges, the AAMC, outlines a set of core entrustable professional activities, or EPAs, required of every medical school graduate. EPA 10 states that medical school graduates must be able to recognize a patient requiring urgent or emergent care and initiate evaluation and management. Specifically, EPA 10 states that the graduate must be able to recognize normal vital signs and variations, recognize severity of a patient's illness and indications for escalating care, and start an initial care plan for the decompensating patient. Essentially, EPA 10 states that graduates should be familiar and able to perform the basics of critical care medicine. But how many medical schools actually require structured critical care training for medical students? From an article in Academic Medicine, as of 2015, only 46 of 136, or 34%, of medical schools required an ICU rotation during the student's fourth year. In addition, a group at the University of Colorado looked at student perspectives on the fourth year of medical school and found significant fear and anxiety surround the choice to pursue an ICU rotation. This trepidation is understandable. For students, the ICU is an unfamiliar environment filled with the sickest patients in the hospital, with severe pathophysiologic derangements and mountains of objective data to comb through. A student could be forgiven for not wanting that experience. Therefore, it is entirely possible that medical students may miss the opportunity to develop the knowledge and skills necessary to care for the critically ill patient prior to graduation. How important are those skills in residency? This graph released by the ACGME for the 2018-2019 academic year shows the percentage of residents training in each specialty. Looking closer at the most common specialties, the 6 largest specialties, internal medicine, family medicine, pediatrics, general surgery, emergency medicine, and anesthesiology, all require residents to provide care for critically ill patients during their training. Overall, between these 6 groups, at least 64% of all currently practicing residents will care for critically ill patients. If every doctor should be familiar with the basics of critical care medicine, and the majority of residents will work in an ICU at some point during their training, what are ways to gain ICU experience in medical school? As previously discussed, a medical school may require an ICU rotation during the fourth year, or likely offers an ICU elective for fourth-year students. Another opportunity for ICU exposure is a third-year internal medicine clerkship at a site with an open ICU, a situation commonly encountered at VA medical centers. The classic ICU structure can also be referred to as a closed ICU. In a closed ICU model, when a patient on the floor decompensates and needs to be transferred to the ICU, that patient is transferred from the primary floor medical team to an ICU team run by an intensivist. In an open ICU model, a primary medical team provides care for patients both on the floor and in the ICU simultaneously. Therefore, when a patient on the floor decompensates, the primary medical team transfers the patient physically to the ICU, but then continues to co-manage the patient with the help of the ICU team. Why transfer a patient to the ICU? What services does an ICU provide that allow us to care for the sickest patients? Patients in the ICU are able to receive more intensive nursing care. While nurses on the floor may work with anywhere from 4 to 6 patients on a given day, ICU nurses care for a maximum of 2 patients. The sickest patients in the ICU may even have a dedicated nurse. Next, the ICU allows for more frequent monitoring and data collection. In the ICU, there are glass doors that allow for constant visualization of the patient, continuous vitals, and the ability to obtain more frequent labs and imaging. The ICU also allows for increased levels of respiratory support. Patients with unstable respiratory status require ICU-level care. In the ICU, patients can receive heated high-flow nasal cannula, non-invasive positive pressure ventilation, and invasive mechanical ventilation. In the ICU, patients can also receive high-risk medications that require minute-by-minute monitoring and adjustment. Examples of high-risk medications include vasopressors, inotropes, sedation, and analgesia. Finally, in the ICU, patients can receive urgent or emergent therapies, including emergent renal replacement therapy, endoscopy, and bronchoscopy. If these are the services an ICU can provide, what types of illnesses require ICU-level care? Common illnesses encountered within the ICU include acute respiratory failure, shock, acute organ failure, for instance renal failure or liver failure, severe metabolic and electrolyte disturbances like diabetic ketoacidosis, hyperkalemia, and hyponatremia, severe withdrawal or intoxication, neurologic emergencies like brain bleeds or acute strokes, and unstable arrhythmias. Recognizing that critical care training is not required of all medical students, but is required for a majority of residents, we have created a 7-session ICU curriculum that focuses on some of these core critical care topics. Our curriculum is designed for multiple levels of learner, including third-year students on an internal medicine clerkship with an open ICU, fourth-year students preparing to rotate in an ICU or currently on an ICU rotation, and interns or residents that may be rotating in an ICU for the first time or need a refresher on core ICU topics. Overall, our curriculum covers ICU presentations, the remainder of this session, IV access, central venous catheters, and endotracheal tubes, acute respiratory failure, shock, and then we build off the shock session and discuss septic shock, hemorrhagic shock, and cardiogenic shock. For the remainder of this session, we are going to review ICU bedside rounding presentations, often one of the more daunting aspects of an ICU rotation. Similar to other inpatient medicine presentations, the ICU presentation should be structured in the SOAP format: subjective, objective, assessment, and plan. First, the subjective. The subjective portion of the ICU presentation begins with overnight events. In order to deliver the most succinct and efficient presentation, overnight events should include only the most significant events that have occurred since the patient was signed out to the overnight provider. Examples of relevant overnight events include any use of the code cart, significant respiratory events, including whether the patient needed to be intubated, proned, or paralyzed, bleeding events, any procedures, and additions or changes to vasoactive medications. Following overnight events, the subjective portion of the presentation ends by presenting the patient and nurse's recap of the night and early morning. After the subjective is completed, transition to the objective portion of the presentation. The objective can be broken down into 2 parts. Part 1 can be thought of as information gleaned from being at the bedside. This includes the vitals, the intake and output, current infusions, and the physical exam. Part 2 is data gleaned from the computer and medical record. This includes labs, imaging, and microbiology. Similar to the subjective, when reporting the objective include information from overnight and the current morning. First, let's discuss what we gain from being at the bedside. The objective portion of the presentation should always begin with the vitals. When discussing the vitals, it is important to always include ranges plus the support required to obtain those numbers. Start with the temperature and report both the minimum and maximum temperature. If the patient has been febrile, include the time of the last fever. An example, temperature 36.5 to 39 at 2100. Next, blood pressure and mean arterial pressure and the current vasopressor requirement. For example, blood pressure 80 to 90 over 50s, MAP 60 to 65 on 0.1 of norepinephrine. Providing the current vasopressor requirement adds critical context to this statement, because a MAP of 65 has different clinical connotations depending on whether the patient is on or off vasopressors. Next, heart rate and any current antiarrhythmic infusions. For example, heart rate 100 to 120 on 10 of diltiazem. Next, respiratory rate, and finally, the oxygen saturation plus the patient's current respiratory support. What are the various types of respiratory support available in the ICU, and how do we report that information? The least intensive forms of respiratory support include nasal cannula, face mask, and non-rebreather. If the patient needs more support, the next step up in therapy includes heated high-flow nasal cannula and non-invasive positive pressure ventilation, CPAP and BiPAP. The most intensive respiratory support is provided via invasive mechanical ventilation. As respiratory support gets more complex and intensive, more values need to be reported. For nasal cannula, face mask, and non-rebreather, we only report the flow rate in liters per minute. For example, oxygen saturation 92 to 94% on 6 liters per minute nasal cannula. For heated high-flow nasal cannula, we report the percent FiO2 and flow rate in liters per minute. For example, oxygen saturation 90 to 94% on heated high-flow nasal cannula at 60% and 50 liters per minute. For non-invasive positive pressure ventilation, we report the percent FiO2 and pressure settings. For CPAP, this requires reporting a single continuous pressure. For BiPAP, we need to report both the IPAP, the inspiratory positive airway pressure, and the EPAP, the expiratory positive airway pressure. For example, oxygen saturation 90 to 94% on BiPAP 60% and 12 over 5. In this example, the IPAP is 12 and the EPAP is 5. Finally, for invasive mechanical ventilation, we report ventilator mode, tidal volume, respiratory rate, percent FiO2, and positive end expiratory pressure, or PEEP. Tidal volume and respiratory rate are always reported together because they control ventilation, and FiO2 and PEEP are always reported together because they control oxygenation. For example, oxygen saturation 90 to 94% on PRVC at 370, 16, 60%, 10. In this example, PRVC is the mode of ventilation, 370 is the tidal volume, 16 is the respiratory rate, 60% is the FiO2, and 10 is the PEEP. After reporting the type of respiratory support and current settings, report the last ABG. When reporting an ABG, first report the pH, then the PCO2, and then the PO2. If relevant, for instance if a patient has ARDS, report the P to F ratio as well. This ratio is calculated by dividing the PO2 by the FiO2 as a decimal. For example, an FiO2 of 90% is 0.9. For example, ABG at 700 on these settings shows 7.32, 38, 74, plus P to F ratio of 220. When finished reporting the oxygen saturation and respiratory support, we are done with vitals, and move on to the remainder of the bedside objective by reporting the intake and output. Reporting the intake and output should include the net I's and O's over the last 24 hours, as well as the net I's and O's for the total hospital course. After intake and output, report the current infusions if they have not already been discussed in the vitals. Examples of infusions include vasopressors, other vasoactives, antiarrhythmics, inotropes, sedation, and analgesia. Finally, the bedside portion of the objective ends by reporting a focused physical exam. The data portion of the objective begins by discussing the labs. Relevant labs include the CBC, BMP, and LFTs. Shown are the fishbone diagrams for these labs. After labs, report on any new imaging studies, including chest x-rays from overnight and the morning. End the objective portion of the presentation by discussing any new microbiology results. During the subjective and objective portions of the bedside ICU presentation, there should be no editorializing of information if possible. After the objective, transition to the assessment and plan. The assessment is a brief one-liner that ends with the primary ICU problem and cause if known. Shown is the list of common ICU illnesses from the beginning of the session. An example one-liner, Mr. Smith is a 65-year-old man presenting with septic shock due to gram-negative rod bacteremia. A plan in the ICU can either be problem-based or system-based. For a problem-based plan, problems are discussed in their order of importance, with the most important and pressing issues discussed first. In a systems-based plan, each organ system is mentioned along with any relevant issues. It is always best to check with attendings and fellows regarding which type of plan is preferred. After the plan is completed, ICU presentation should end with a brief ICU checklist, which ensures that patients are receiving appropriate evidence-based supportive care. The ICU checklist typically includes: are we feeding the patient? Is the patient receiving DVT or VTE prophylaxis? Is the patient receiving stress ulcer prophylaxis, famotidine or pantoprazole, which is typically provided to all intubated patients, code status, and the patient's contact, proxy, or MD-POA. Shown is an ICU presentation template that summarizes what we have discussed in this session. This template was constructed to help learners organize their bedside ICU presentations. This template can be screenshotted and saved, or printed to help on rounds. In summary, in this session we reviewed ICU training in medical school, described the purpose of the intensive care unit, identified a method of presenting vital signs in the ICU, including vasopressor requirements and ventilator settings, and demonstrated a systematic approach to presenting the objective portion of the bedside rounding presentation. Thank you for your participation.